All righty, are we ready to get going?
Ready?
All right. Welcome back, everyone. This is our third training session of the day. Thank you, Karen, so much again for being with us today. I'm just going to go over a few housekeeping rules for the folks who are new. Just to please stay muted throughout the entire training and hold your questions and answers until the end. There will be time to answer questions at the end of the presentation. You can drop them in the chat. Also, this same Zoom link is what we are using throughout the day. So if you're planning on coming back and attending any of the trainings, there are going to be 3 more throughout the rest of the day. So you can just either jump on and off this Zoom link, or you can just stay on. There will be a break in between this and the next one. There is going to be a 30-minute break in between this and the next one, and it'll start at 12:30. And your community is responsible for tracking your attendance at this training session today. So make sure your community knows that you are in attendance. Thank you again. We are so pleased to have Karen with us to present on infection control and the principles of universal precautions. Karen has been a registered nurse for over 30 years in the state of Massachusetts. Over half of her career has been caring for and about seniors in senior living environments. Her current role is the Chief Nursing Officer for Einstein Flaherty LLC. She is a board certified in infection control and epidemiology and has spent the last 3 years navigating through the challenges of the pandemic, being on the front lines and working directly with the Mass Department of Public Health, supporting over 100 senior living communities. Karen has provided guidance and training to assisted living residences, skilled nursing facilities, and rest homes on the topic of infection control. Her on-site facility visits focus on risk mitigation to prevent the spread of infectious diseases and educating staff on disease transmissions and how to best manage an outbreak. So with that, I am very
Recording in
excited
progress.
to introduce Karen, and thank you so much again for being with us today, and I will pass the virtual microphone to you.
Thank you so much, Christina, and a special thank you to MassAlla for having me here today. So hello, everyone. Thanks for joining. I want to take us back to December of 2019. My daughter, an ER nurse at the time, became very ill, and she was extremely lethargic, had a very sore throat, a cough, and a fever. And she was tested at the time, of course, for influenza, the flu, and strep throat, and all of her tests came back negative. So, when that happens, they label, this infection as some sort of virus. So I remember thinking at the time, what is this virus? And are we going to see more of it in the next few months, as it was, really gearing into cold and flu season, December 19 to January of 20. So also, I recall thinking about, this is my healthy 25-year-old daughter who's, wiped out for 2 weeks and even longer with shortness of breath and falling oxygen saturation levels, being treated with nebulizers and inhalers. What could this possibly do to, our residents in senior living should something like this occur? Fast forward 2.5 months later, and we're in a state of emergency related to this virus, this novel virus that was, a lot of it was unknown to us. And, we started to develop, and receive more and more information about, certainly what this virus was. So infection control has been at the forefront, certainly for the past 3 years. All of us know that. But the basic principles have remained the same or unchanged. And really, this is what our focus will be about today. So we have some objectives today. So we'll understand infection control and the principles of universal and standard precautions and bloodborne pathogens based on OSHA guidelines. We'll discuss standard and transmission-based precautions, identify and understand how to manage communicable diseases in our residences, techniques for proper hand washing, the role of the environment in infection control, which certainly has been a major focus the last couple of years, and certainly breaking the chain of infection and the use of personal protective equipment and hand washing. So really taking us back to basics here with our infection control practices. So it starts with a pathogen, right? A germ or a microbe, a microorganism that causes disease to its host. So there are basically 5 main types of pathogens. So we'll talk about viruses, very small microbes that reproduce in the body and cause illness. An example of a virus is HIV, the human immunodeficiency virus. Viruses are not treated with antibiotics. We do have antiviral medications, which we'll talk about in a little bit. Bacteria are microorganisms that are a little bit larger in some cases than a virus, causing illness. Examples of bacterial infections include Staphylococcus, Streptococcus, E. coli, meningitis. Fungi invade the tissue. They can be confined to the skin or actually spread into the tissue, the organs, and the bones. And examples of different types of fungi include athlete's foot, ringworm, and yeast infections. Protozoa are very small. They're single-celled pathogens that can cause disease. Examples include malaria, giardia, toxoplasmosis. And then we have worms as well. Flatworms, roundworms that can invade us and make us ill as well. So the main thing to remember here is that there has to be a pathogen or a microbe causing disease agent that infects us to become ill. So we've all probably seen this little diagram here and breaking the chain of infection. So it's important for us to understand that, you know, we do have this chain of infection, and it does involve and starts with an infectious agent. So something, like I said, has to be present for us to become sick. It has to be a pathogen. And then we really move on to the source. So could it be people? Could it be equipment? Could it be water? What is that source that this pathogen is living in? And really off to the side here, and this is why I love this slide, can really get involved with your staff and say, you know, really at this point, you know, what are your policies? You know, your environmental sanitation, what are you doing to disinfect, sterilize, and clean? Then this pathogen has to exit that source. It can be through aerosols, through splatter, and certainly here's where hand washing, and you can see if you go around the chain, hand washing is in several of these. And how do you control, you know, this spread when it comes to exiting the source? The means of transmission. So how is this pathogen going to be shared? How is it spread? You know, certainly we have direct contact, we have indirect contact, airborne. We'll talk about the modes of transmission coming up, but, you know, here's where we tend to look at isolation. You know, does the resident with a communicable disease need to be placed in some sort of, you know, specialized room, specialized area so that others, you know, really to work at mitigating the risk of transmitting that infection. And there we have hand washing again. So for breaking that chain. So in any part of this chain, we really want to break it so that the infectious agent doesn't move into the susceptible host. And then we have a portal of entry. Certainly we know that mucous membranes, the respiratory tract, broken skin, how is this pathogen going to get into its host? And you really want to look at things like first aid, personal hygiene, hand washing again, but certainly we know that intact skin in keeping ourselves healthy is certainly the best way to prevent that spread really entering into our bodies and then flourishing to cause illness into the susceptible host. So that's why it's important to treat underlying diseases. We certainly have heard a lot about people being immunocompromised, and certainly how communicable diseases can affect them differently. And here's where our immunization comes into play as well, and our vaccinations that we have available. So really, there are two organizations that are at the forefront that, have really presented us with guidance, directing us through management of infection control, communicable diseases. So we have OSHA, the Occupational Safety and Health Administration, created in 1970. And OSHA really is responsible for making rules for safety in the workplace to prevent injuries and illnesses related to work. And really the intent of OSHA is to protect the worker. And we also have the Center for Disease Control and Prevention, a United States federal agency under the Department of Health and Human Services. It serves as a national focus for applying disease prevention, control, environmental health, health promotion, and health education. It is really designed to improve the health of people in the United States, and has certainly become well known to us in the past 3 years with the pandemic.
Here barely here. I don't know what the voice. I've never had any problem all morning.
So one thing we need to talk about when we, discuss infection control is certainly universal precautions. And universal precautions were recommended by the CDC.
Nancy, tell me if it's too loud.
In the 1980s.
Is it good?
It's too loud.
Oh, somebody just has to mute themselves. That's all. And universal precautions is really the practice of avoiding contact with body fluids by means of wearing protective gear, personal protective equipment. That includes gloves, goggles, face shields, gowns. And it was really introduced as an approach to infection control to protect workers from HIV and HBV, which is the hepatitis B virus, and other bloodborne pathogens, regardless of the patient's infection status. So I think we can all remember, some of us back in the 1980s when HIV was really on the rise, and how could workers protect themselves for potentially being exposed to blood or body fluid. And that's when the CDC initiated universal precautions for all of us to follow in healthcare. Then we move on to standard precautions. And a lot of people will ask me, Karen, what's the difference? Is it universal precautions? Do we call it standard precautions? Well, standard precautions were introduced in 1996, so more recently. And what they did, the CDC was added additional elements to universal precautions, not only from pathogens in human blood so much, but also pathogens in other body fluids. So it really is the minimum infection prevention practices that apply to all patient care, regardless of suspected or confirmed infection status, in any setting where healthcare is delivered. So certainly in our assisted living residences, it's designed to protect the healthcare providers and to prevent the healthcare providers from spreading infectious agents among patients. And standard precautions, while it does include putting a barrier between us and anyone's blood or body fluid, it incorporates hand hygiene, the use of PPE, respiratory hygiene, and cough etiquette. And that's where, you cough into a tissue, you get rid of the tissue, you immediately clean your hands. you cough into your elbow, really avoid that contact with any droplets on your hands directly. Sharp safety is included in standard precautions, taking a look at engineering and work practice controls. Are we using the appropriate devices to for any type of syringes, any lancets? Do we have the latest syringes that will self-cap and self-sheathing syringes? So sterile instruments and devices, really taking a look at what of our sterilization practices and certainly our disinfection practices and processes, and clean and disinfect environmental surfaces. So the bloodborne pathogen standard, OSHA introduced this. And OSHA, it's an OSHA standard really related to healthcare, and it requires employers to protect workers against exposure to health hazards who may be exposed to blood and other potentially infectious materials, including body fluids. And certainly all of us that work in assisted living residents know that we certainly do have the potential at any time to be exposed to blood or body fluid. So what can we do, and what does this bloodborne pathogen standard say? So it includes the work practice controls, the hepatitis B vaccination being offered to all associates that join our teams at no cost. Hazardous communication, so it requires all employers to provide information and training to employees about the hazardous chemicals in which they may be exposed to at the workplace. It includes chemical inventory, written plans, labels, material safety data sheets, and training. And then, of course, training and record keeping down at the bottom there, which is so critically important to understand and look for root cause analysis and how we can make things safer. I really liked this picture because I think it, in one slide, it really takes you through the bloodborne pathogen standard, and it talks about protecting yourself, knowing the rules, or certainly being familiar with your company's exposure control plan and your policies. Your vaccination requirements. We've all had to create policies, requiring vaccinations and what the standard would be and what would be best to protect our workers and certainly our residents as well. Know your colors. Certainly anything in a red bag should make you stop and be aware that there could be potentially infectious material in this bag. Read all the signs and the labels. Certainly if there's signage on any resident's door, on a unit going into a certain, maybe it's a special care residence or a wing of your facility, read that signage and understand what's involved as far as keeping yourself safe and the residents safe. Wear the right equipment. And certainly that involves making sure that you know how to put on that equipment appropriately, how to take it off appropriately, what you should wear then. And, certainly when I talk about infection control, it's so critically important to understand, how this disease is transmitted. We'll get into that with transmission-based precautions, but how is it transmitted? Where is it in the body? It's one of the first questions that I, certainly will ask and discuss with anyone who reaches out for some guidance. Hand washing. The number one way to prevent the spread of infection certainly is washing our hands. Making sure that we dispose of any type of lancets or any type of needles, syringes correctly. Never recap, never bend, certainly a needle or a lancet, and it should go from the point of care or use directly into that biohazard container. Don't lay it down, don't place it in a resident's bed. I did have a RCA one time who was picking up the resident's trash. She was stuck by a lancet, and the resident was just disposing her lancets in her trash. So, taking a look at that, if you have anybody using those type of devices in your community. follow proper disposal, keep it clean, keep the workspace clean, and don't forget all body fluids should be handled as potentially infectious. A little bit about labeling. We do see these warning labels, and here's our standard biohazard labels. You'd be surprised at how many refrigerators I open that do have the biohazard label on them that have staff lunches in there along with biohazard materials. So, take a look at where you're storing things. So they're warning labels. They should be affixed to containers of regulated waste, refrigerators and freezers containing blood or other potentially infectious material, and other containers used to store or transport or ship blood or other potentially infectious materials. So one thing, I really did focus on a lot when I was providing education regarding COVID is going back to really educating on transmission-based precautions. And what these precautions are is they really augment, the standard precautions, and there are additional precautions that are put in place depending on how the germs and the pathogens are transmitted. So if you can remember A, B, C, D, it really can help you focus on transmission-based precautions. So for contact, bloodborne, droplet, and airborne transmissible diseases, transmission-based precautions augment standard precautions with additional controls to interrupt the routes of transmission, because that's what we are striving to do, is put a break in that chain of infection. So the bloodborne pathogen standard that we just spoke about requires the use of universal precautions to protect workers against pathogens found in saliva during dental procedures. So that was big back when universal precautions were, were really starting to evolve in the 80s. And in cases where it's difficult and impossible to differentiate between body fluids that potentially could be mixed with blood. And just, this picture kind of tells it all here, but, the range of a sneeze, and I'm sure we've all seen the videos and things about how far a sneeze can travel, but, just to put it in perspective, sideline to sideline on a football field is about 160 feet. And, we're talking about the range of a sneeze being from 27 to 200 feet. So certainly we know that particles can travel, at incredible lengths through the air. So here's your ABCDs. So, I kind of put it in this way on purpose because I think if we think about it in those, kind of that order, that we can really train and understand what we need to do to protect ourselves and our residents. So if you start with A for airborne, so airborne precautions apply to patients that are known or suspected to be infected with microorganisms that can travel long distances in the air. It does include diseases like varicella, COVID-19, and certainly preventing transmission requires personal respiratory protection, special ventilation, and air handling, and certainly PPE here. So we'll talk about this a little bit more. Then we move on to our B and our bloodborne based precautions. So the blood of an infected person comes into contact with the bloodstream of another person. Blood and bloodborne pathogens are sometimes present in other body fluids, so we do have to remember that, such as urine, feces, saliva, emesis, includes HIV, AIDS, and hepatitis B. And preventing transmission includes making available that hepatitis B vaccine that we talked about, identify and use of approved environmental controls, and personal protective equipment as well. Moving down to C, this is our contact precautions. And we can have direct or indirect contact with these microorganisms that can cause the spread of disease. So certainly that means direct contact person to person, where indirect contact is more where it is a person that could be infected with a pathogen that could be on a bedside table, elevator buttons, indirect contact, not being person to person. So, we examine that very closely in the last couple of years. So it includes conjunctivitis, scabies, MRSA, the norovirus, C. diff, which we'll talk about. And certainly prevention includes diligent hand hygiene. And we need to make sure that all of our staff are aware that if you have a resident on contact precautions, that you really need to incorporate very diligent hand hygiene practices and hand hygiene with soap and water. Some of our C. diffs, things like that, will not be eradicated or rinsed from our hands using hand sanitizer. So we have to use soap and water, and it's really the friction that's responsible for really, breaking that chain and getting rid of any pathogens that may be on our hands. And then D are our droplets, similar to airborne. Some microorganisms, only travel a short distance in droplets. Certainly, if you've ever been coughed on or sneezed on, you're certainly aware that droplets can travel. There's some question and some research being done on how far they do travel, but here are your things that travel short distances through the air. They include influenza, pertussis, COVID-19. I kind of put in the airborne and droplet because we use isolation precautions now. So, they're looking at about 6 to 10 feet or so with droplets, but certainly spread through the air. So you need to keep that in mind as well. So airborne precautions, what actions do we need to take to prevent any transmission of pathogens that travel through the air? So we talk about gloves, we talk about masks being worn, at the right times. Maybe your facility that's initiated mask use during high, flu rates, during flu season, things like that, perhaps for associates that haven't been vaccinated and things like that. So strict cleaning and disinfection of surfaces, ventilation, make sure that's appropriate, positive pressure, negative pressure rooms, which we would see certainly in an acute care setting like a hospital. But, for us in the ALs, really take a look at, can you incorporate fresh air? Can you open the windows? Keep the residents safe, of course, but can you really have some of that airflow through the environment? There are air purifiers. I work with several communities that have actually added air purifiers with HEPA filters to resident rooms, certainly in common areas and things like that. And, UV light, I think most of us can remember that, back in the beginning of COVID, we were incorporating the use of UV light, whether we put our phones, certainly in a container that, where they were exposed to UV light, or our keys or things like that. So. And then really take into account considerations. If I have a community call me and say, Karen, I have, this virus that's going around, and, I'll say, okay, tell me more, let's talk. Are they in a shared room? Do they go to the dining room, activities, things like that? What is your notification process to staff? It's really important to let the staff know what's happening. And, it's really, that fear is brought about with the unknown. So certainly communicate with your staff, notification to visitors, to families, what's happening, what we need you to do to control the spread of any type of disease or outbreak we have in our community at that time, and reporting to appropriate agencies as well. We'll move on to bloodborne pathogen, the actions that we can take, treat all blood and body fluids as potentially infectious. And that's really where it all starts. Contaminated needles and other contaminated sharps we talked about will not be bent or recapped. When you look at incidences of needle sticks, and you look at work practice controls, and sometimes, possibly someone could have been stuck with a needle because they were attempting to recap a used needle. So you look at those practices, and certainly now we have engineering controls to help with that. So bending, recapping, or needle removal must be accomplished through the use of a mechanical device. Store razors appropriately to prevent accidental cuts, and you may turn to a more electric razors to use. I did have an RCA at one time reach into a bedside table to grab the wash bin for one of her residents, and there was an uncapped used razor in the basin, and she did cut herself. So, something I always take a look at is how are you storing those razors? What happens to the disposable razors after use? What is the storage? Is it one-time use and then directly placed in an appropriate biohazard container? Immediately or as soon as possible after use, contaminated reusable sharps shall be placed in appropriate containers until properly reprocessed. Not put in your pocket, not laid down on bedside table, not placed in someone's bed. And certainly these containers should be puncture resistant, leak proof. And I think all of our ALs certainly do have some type of biohazard containers. So contact precautions. We talked about that this can be transmitted through direct contact or indirect contact. Some examples would be our C. diff, our norovirus. I am working with a community right now that does have an outbreak of norovirus. So, I just caution you too of, making sure you have an accurate diagnosis before you start calling, a GI illness as a norovirus. Have that sample processed through the lab to get that definitive diagnosis if you're going to label it norovirus. You really want to make sure that you have that proper diagnosis. So certainly actions to take when there's a contact precaution sign, you certainly don all your PPE before you enter the resident's room. Understand what specific agent of disease is present. Arm yourself with knowledge. Something that we did talk about, certainly we've paid more attention to and talked about in the last couple of years was laundry and the management of contaminated laundry. How do we process that? What's the correct procedure? Keep your hands away from your eyes, your nose, your mouth. This is really back to basics, but you'd be surprised at how many times I would go in to assess residents that was having an outbreak, and how many times the staff would touch their masks and then not wash their hands. So, something we just need to break those habits and just, offer consistent reinforcement, which, if you're touching your eyes, nose, mouth, or your mask, just to, make sure that you wash your hands. Follow standards for cleaning rooms, bathrooms, surfaces. What is the process for cleaning if you do have a communicable disease in your facility? Are the housekeeping staff aware of what's happening? Do they clean that room last? Really, what is that procedure? Considerations, just like before, does the resident share a room? Do they share a bathroom? Very important to know. Should visitors be alerted? Appropriate communication, and then, of course, required reporting. Droplet precautions, the vigilant hand washing certainly comes into play with all the precautions, gloves, gowns, masks at the right time. And, really what is that diagnosis of that pathogen, that disease, and how are we going to prevent those droplets from going from one person to another person? We implemented a lot of social distancing over the last few years. It's interesting how we saw our flu rates really decline when people were taking precautions related to COVID. So they do work. So let's talk about hand washing, so critically important. And if you are doing competencies with your staff, good for you, you should be. It's so interesting to watch people, wash their hands. We certainly know that it's the #1 way to prevent the spread of infection. I think Hand sanitizers, the use has grown immensely over the last 3 years. We see hand sanitizer everywhere. You know, you certainly want to make sure that any hand sanitizer that you're using has at least 60% alcohol content, and you can find that right on the back of the label. Some of the ones that, you know, smell good or, you know, have aloe, you know, they don't have that 60% of alcohol, you know, which won't be effective in preventing the spread of disease. So when should people wash their hands? Certainly entering and leaving a resident room, before and after care, before, during, and after preparing food, before, during, and after, you know, you can incorporate this with your residents as well and offer, you know, hand gels and hand washing, things like that. We just make it an activity that just happens now. Certainly after using the restroom, blowing your nose or coughing, after touching an animal, after touching garbage, or anything that you feel like there could be something on there where your hands, you know, certainly may have come into contact with any type of microorganism. I do find education with hand washing is something that is always assumed, right? And then you start to do the competencies and do the audits, you know, some rounding during the day and on all 3 shifts if you can, and really see what's happening with the hand hygiene. You know, what I find often is that people rely on gloves so much that what happens is that, you know, they feel that if they're wearing gloves, they're absolutely safe. They take off the gloves, they put on another pair of gloves. And really to break that chain again, it's, you know, removal of gloves and then immediate hand hygiene needs to take place before placing on any new gloves. So. Bloodborne pathogens, a couple of diseases that are carried in the blood that, you know, we needed to touch upon. We've talked about the hepatitis B, where there is a vaccine for hepatitis B, and very happy that there is. Hepatitis B is, you know, a very strong virus, and it can actually live on surfaces. So, you know, it's a little bit stronger than, say, your more virulent than your HIV, which when the HIV virus comes into contact with the air, it doesn't live for very long. So just something to be aware of. So what is hepatitis? B and C are both bloodborne pathogens. B, we know, has the vaccination available. It's a series of 3 IM right into the muscle injections. And hepatitis B can live up to a week in dried blood. There's actually other research that says it can live even longer. Hepatitis C right now, there is not a vaccine available. However, they're working on that. And certainly HIV, you know, the medications to treat HIV have certainly come so far and, you know, really prolong people's life expectancy, certainly when there's an infection of HIV. So just taking a look at this, hepatitis is an inflammation of the liver. Some people have no symptoms at all. We had a blood, one of the blood draws at one of our schools, like a blood drive, and one of the students at the school donated blood, and that's when she found out she had hepatitis C. She didn't have any symptoms, and she had actually had a blood transfusion as a baby. So you can kind of see where that's a little bit frightening. You know, you may have no symptoms, or you may have some fatigue, some nausea, loss of appetite. You may see some yellowing, or we call jaundice of the skin and the eyes. And certainly causes is contact with infectious blood, sharing contaminated needles, mother to newborn, unprotected sex. Both can progress to chronic and lifelong infections and cause liver damage. And it may be treated with antiviral medications to slow the disease process. And HIV, this virus actually damages the immune system of the body, so that when there are other infections introduced, you know, it has a tendency to take over the body and can cause irreversible damage. So you may see fatigue, weight loss, forgetfulness, fever, headaches, swollen glands, things like that. So, not a cure, but medication to manage the symptoms and prolonging life have been very important that have come out in the past couple of years. If you have an exposure to a bloodborne pathogen, if you have a needle stick or you're cut by a contaminated sharp object, like my RCA with the razor, if you have contact of the eyes, nose, mouth, mucous membranes, or non-intact skin with contaminated blood, follow policies and procedures of your exposure control plan, which all of your communities will have. Certainly, if you have an exposure, you want to wash the area immediately with soap and water, flush the nose, the mouth, the skin, irrigate the eyes, report the exposure, and certainly seek the advice of a healthcare professional for follow-up actions as necessary. So the use of personal protective equipment, when to wear PPE, and certainly when I worked with my communities, my assisted living residences, I would certainly have them gear up the end of November, December, to make sure that they had personal protective equipment, especially, knowing that we're going into the high infectious disease months, December, January, February, March. So really, when do you wear it? When there's any chance you could have contact with blood or body fluid. Gloves should be worn if there's potential to come into contact. Masks with face shields should be worn if there's risk of splashing. Certainly with our airborne and our droplet precautions, if any splashing can get into our eyes, our mouth. Gloves should be worn if there's a risk of clothing contamination. Goggles should be worn if there's a risk of splashing into the eyes. And I did have an RCA that was splashed with urine when she was emptying a Foley catheter. So you might want to look at your practices with that, and just to make sure that the right PPE is in place when there is a potential for splashing. Proper procedures for putting on, donning, and removing, doffing, mask, gowns, gloves, competencies, observations, and I truly believe in real-time education as well. When you're out there on the units, take a look. We're all in this together. We're all trying to protect our residents and our staff. And if you can make minor corrections on the spot, make a big difference. Shoe covers and the use of goggles. Something that should be really discussed, of course, during orientation and then annually. And certainly if you have an outbreak as well, you just want to have those reminders. So engineering controls to minimize exposure. These are work practice controls. Employers provide hand washing facilities, which are readily accessible to employees. We discussed a lot in ALRs about, where we put the mounted hand sanitizer machines. Do we have self-standing? Where are they located? Are they at the point of care? Is there ease of use? Are they, carrying individualized hand sanitizer in their pocket? Whatever makes it easiest to use and implement is what we need to go for. Employees shall ensure that employees wash their hands immediately or as soon as feasible after removal of gloves or other PPE. And just an FYI too, with PPE, I mentioned that it should be in place prior to going into a residence room that, has or potentially may have a communicable disease. But that equipment should be taken off prior to exiting the room. I get a little nervous when I see staff walking in the hallways with gloves or gowns or, where are you coming from? Why are you wearing that? Some people are donning 2 masks. Let's talk about that. What's the safest for you? So engineering controls should be examined and maintained or replaced on a regular schedule to ensure their effectiveness. Who's filling the machines? Something as simple as, is there soap and paper towels in all the bathrooms that our associates or residents may use? A little bit about our laundry that we touched on. So contaminated laundry, of course, should be handled as little as possible. It should be bagged or contained at the location where it is used, not carried throughout the hallway. When a facility utilizes universal precautions in the handling of all soiled laundry, alternative labeling, color coding is sufficient. Whenever contaminated laundry is wet or presents a reasonably likelihood of a soak through or leakage, please make sure it's transported in bags that are leak proof. And the employer shall ensure that employees who have contact with contaminated laundry wear personal protective equipment. Community consideration. So certainly what we're here doing today is just some basic education to residents, families, visitors, and care providers about disease transmission and how the illness can be prevented. You may post something, ask family members, visitors, please don't come in if you're sick. Use of posted signs with instructions and pictures are very helpful for cough etiquette and how to wash your hands correctly. Perhaps you have donning and doffing pictures, at the places where that may be taking place. Availability of tissues, masks, separation of a person if they are ill, what is most appropriate for that resident, and really stress the importance of hand hygiene, which I know all of us are doing. So just an example of some of the communicable diseases that we've seen out there. We've all seen them. I'll just touch on them briefly. Certainly cold and flu season is upon us, and we know that there have been some cases of flu, although minimal. Coughing, sneezing, we have influenza A or B, we have the body aches, the weakness, and certainly, your facility's policy on vaccinations. Are they being made available to the staff and the residents? We have MRSA that we see in some of our facilities. And the first question that I always ask with MRSA is, where is it? The way you're going to manage it is different if somebody has MRSA in their lungs, as opposed to maybe MRSA in a wound. So, where is it? And then you can figure out, how it's going to be transmitted and then mitigate the risk. C. diff occurs when, a resident could be on antibiotics to treat another infection. And sure, it kills off the bad bacteria, but also the good that keep the C. diff under control in our bodies. And, certainly it causes severe diarrhea. It can contaminate surfaces. I want you to think about toilets, who's sharing the toilets, handles, bedpans, commodes, bedside tables. I think I mentioned too, just be very, very specific at cleaning processes and making sure that if you have C. diff in your community, all the associates are aware that proper hand washing is the way to prevent the spread of the disease, and certainly using PPE and contact precautions. Urinary tract infection is the most common infection in long-term care. Certainly transmitted through, it can be transmitted through the hands of healthcare providers. So we really want to be cautious with that. Take a look at, what the specific counts are, the UA, the CNS, and really take a look at, making sure we're not overusing antibiotics, which then, we get involved in some multi-drug resistant organisms. They switch a little bit, the microbes, and try to outsmart us with our common antibiotics that we would normally use to treat a UTI, or another infection. Shingles, I do get a lot of questions about shingles. Same virus that causes the chicken pox. If someone does have shingles, you want to make sure, again, where is it? Is it in someone's eye as opposed to perhaps on their body? That can be covered up. So, there are vaccines for shingles recommended for people over 60. Preventing the spread of the disease includes keeping the rash covered, certainly not touching or scratching the rash, washing hands often. Certainly if someone has blisters that are weeping or oozing, make sure they're covered and take precautions with that. You want to make sure that any of your staff that hasn't had chicken pox, you may want to modify their assignment to not take care of a resident that does have shingles. So, and one of my favorites, scabies, right? So, this is a condition caused by mites. We certainly know it causes intense itching and a rash on the skin. super contagious, physical contact, skin to skin contact, sharing clothing, bedding, towels. Here's another communicable disease that I want you to make sure you get a definitive diagnosis, which involves a skin scraping before you start, really calling any rash scabies. Let's make sure that we have it properly diagnosed and that we know how to treat it effectively. There's a little bit more on VRE, which, we do sometimes see. Treatment includes antibiotics other than vancomycin. And once again, another question about where is it? Is it in someone's urine? Is it in someone's stools? And really, how can we prevent that from reaching another resident? The neurovirus, it's out there, most often circulates during the winter. Symptoms include diarrhea, vomiting, stomach pain, usually a very fast disease. The symptoms usually persist for about 24 hours, but you really want to make sure that, if you have staff that have it, they stay at home until the illness is resolved for 48 to 72 hours, and certainly watch your residents and make sure that you have an accurate line listing, certainly when you have any outbreak in your facility. Some information about TB, certainly something that we're all aware of, as now our regulations in assisted living really want our associates to have a physical, a TB test. And there's a difference between certainly a latent disease, which is something that we're infected with that's not making us sick, versus an active disease. So I know we're running close to time, so I'm just moving on a little bit, but certainly you can see that in the US, 80% of active TB cases are a result of untreated latent TB infections. So we really want to make sure that we are testing our associates for TB, whether it's through a screening for symptoms, whether they actually have, a TB test, a blood test, or certainly the standard MAN2 test. A little bit about coronavirus. I don't think we can give a presentation about infection control without mentioning it. So we certainly know all too much about this, I would say. It's a virus, and we all recognize that symbol on the right there. Right now, most people will experience mild to moderate symptoms if they are infected with the coronavirus. Older people with underlying medical conditions are certainly more likely to become more seriously ill. Prevention, social distancing, making sure that masks are well fitted, and washing hands. And we certainly, have learned about N95s and the importance to have them fit tested to make sure that they fit us appropriately. It's an OSHA standard that we are required to follow. Vaccinations we know are available, and there is treatment for coronavirus as well through Paxlovid, which is a pill that you would take by mouth. And there is an IV treatment as well, remdesivir, if you're unable to take the pill. So a lot is, we know a lot more than we did, and we have actually some tools in our toolbox that can help us, if there is some sort of outbreak in our community with coronavirus. Just a slide on coronavirus versus the flu. Going back to my daughter, the symptoms were very similar to the flu. They're both very contagious respiratory diseases, but they're caused by different viruses. And you really want to make sure that you have the proper swabbing, proper diagnosis, for treatment. We do know that there is treatment for influenza as well, the Tamiflu. There are some tests that can differentiate between flu and COVID at the same time. Those are just wonderful that are out there now. And if those aren't available, then the test may be provided separately. So infectious disease management, are your infection control policies current? EOEA referred to DPH, frequently when it was, speaking about really the management of communicable diseases. Do you provide job-specific education and training? Notification to EOEA as required, ensure competencies, really get those competencies in. I recommend on orientation and annually, and if you have an outbreak. Line listing, so critically important. It really keeps us on track of, when something started, how many people are, infected still, how many people, has the infectious process resolved in. Standard precautions for all residents. Ensure that there's proper cleaning processes, that they're using the EPA registered disinfectants. Ensure all PPE and hand washing supplies are readily available to staff. They can't be locked up. We know infectious disease doesn't just, come about Monday through Friday, 9 to 5. It's usually on Friday afternoon and the weekends where we may have a diagnosis. So please make sure that PPE is readily available to all staff. There is also an infection prevention specialist certification through CDC in infection control. It's a free course. And if you just Google that, you'll find, I found it an excellent review of infection control practices, particularly for long-term care and ALRs. And you do receive a certificate at the end. So it's everyone's responsibility to adhere to proper infection control practices in every department. So we're all involved in this together. Infectious disease management, let's see, we talked about that. The exposure control plan that was mentioned earlier, it is a written plan that all your communities will have, and it will really talk about how to manage, certainly if there is an exposure, what needs to be done. So it should be reviewed annually, so yearly, to reflect changes in technology that will help eliminate or reduce employee exposure. So us in the assisted living realm and really related to our regulations. So 12.068A states in our regulations that the residents must implement a plan to prevent and limit the spread of communicable diseases. The plan shall conform to the currently accepted standards or principles of universal precautions based on DPH guidelines, and shall include the following components: a system to effectively identify and manage communicable diseases, organized arrangements to provide necessary supplies, equipment, protective clothing, and a process for maintaining records of illness and associated incidents involving staff. So if you haven't taken a look at your communicable disease control plan, please do. Make sure it's updated with respiratory illness. You can label influenza and coronavirus right on the top of that. What you're doing for, fit testing, when you would initiate possible universal use of masking and things like that. So if anybody needs help with that, they can certainly reach out. So, and I think that's it. So I think, 11:58. We have a few minutes for questions. If anybody has any, or I can email you answers or whatever you think. So hopefully you learned something. I hope it wasn't, too back to basics, but I think there's so much for us to learn, and I think a refresher on it is so important to keep everybody safe and healthy.
I agree. Thank you so much, Karen. So yeah, feel free, folks, to drop any questions in the chat, or if you want to unmute yourself and ask a quick question. Erin, I do have a quick question. Do you, as we're, heading into December now, have you heard whether there is a rise in COVID cases or flu cases or RSV cases, especially in the senior living communities in Massachusetts?
Absolutely. And, we had a period there where we kind of, we saw this spike kind of October, November, and then it kind of leveled off a bit. But what I can tell you is, I'm seeing more and more communities that are having outbreaks again of COVID, certainly being, ground roots in the communities. I am seeing more and more COVID outbreaks. Flu has actually been very minimal, knock on wood. I hope it stays that way. And I do think that's our diligence with all our practices with hand hygiene and mask use. But COVID, I think, from what I'm seeing, is on the rise at this point. DPH has a pretty good website that can, take a look at where specifically your community is and what your rates are, countywide and that. So it is. I'm seeing it on the rise. Certainly, please don't rule out norovirus too. It's out there. Make sure, start your education now. What are you going to do? What's the process for maybe curbing everyone going to the dining room?